Dr. Smilin, can you please start?
Yes, ma'am.
Yeah.
Uh, Hello, good morning. I'm Dr. Smilin, one of the doctors in the ward today. Uh, I can see from your notes that your GP has referred you because you are having some problems with your breathing. Is that right?
Yes, doctor. I've been having breathing issues for the last
Uh,
2 months now.
uh, how may I address you during this consultation?
You can call me Raj.
Okay. Okay, Raj. Can you tell me more about your breathing problems?
Yes, doctor. I've been having this breathing issue for the last 3 months now. And initially, I thought it would get better, but I don't see any difference, doctor. It is getting worse, in fact.
Uh, have you tried to take any medications?
No, doctor. I never tried any medications.
Okay. Uh, how is it affecting your daily life?
It's horrible, doctor. Like, I'm not able to do my day-to-day activities properly. I have to take
Okay.
rest multiple times. So it's really bothering me.
I'm really sorry to hear that, Mr. Raj. We'll find out the reason for your breathing problem. Apart from the shortness of breath and the breathing problem, do you have any other complaints,
Like what, doctor?
like any chest pain?
Uh, no, doctor. I don't have any chest pain.
Okay. Any racing or pacing of your heart?
No, doctor. I don't have that.
Okay. Um have you ever experienced this shortness of breath when you're lying down?
No,
Okay.
no, doctor. No,
Okay. Is this breathlessness seems to worsen during the night time?
no.
Okay. Uh, do you have any leg swelling?
Yes, doctor. I notice leg swelling on and off.
Okay. How long do you have this swelling?
It is not there as of now, doctor, but I noticed a
Okay.
couple of times. For the last 4 months, I noticed 2 times.
Okay. Um, is it in both legs or in one leg?
It's there in both of my legs.
Okay. When you're trying to press it down, is it w- uh, getting it's going inside or
I never observed that, doctor. I didn't try to do that.
okay. Do you have any tummy pain?
No, doctor.
Okay. Do you have any cough?
No,
Okay. Any sputum production?
no,
Um, any have you noticed is there any problem with your water and bowel works?
no, doctor. I don't.
Okay. And do you have are you eating more than usual or drinking more water than usual?
No, doctor. Not really.
Okay. Do you have any uh, involuntary movements in your hands?
No,
Okay. Have you ever noticed any weakness in any of your limbs?
no, doctor. I didn't.
Okay. Do you have any headache?
Yes, doctor. I have headaches.
Can you tell me more about it? How long have you been experiencing the headache?
I am noticing this for the last 6 months, and I
Okay.
have tried many painkillers, but nothing is helping out, doctor.
What painkillers have you tried?
I tried paracetamol, not so much,
Okay.
maybe twice or thrice in a month. That too when the pain is
Oh,
severe. Yeah.
okay. Uh, can you tell me the exact location of this pain in your head?
It's all over my head, doctor.
Mm. Is it coming and going or is it persisting?
It's coming and going.
Okay. Um, can you tell me the character of this pain? Is it uh, burning or pricking type of pain or stabbing type of pain?
It is a dull kind of pain, doctor.
Okay. Do you have any associated vomiting
Uh,
along with this headache?
No, no,
Any double vision?
no.
Okay. Is there anything seems to worsen this condition?
I'm noticing this worse in the mornings, doctor. As the
Okay.
day goes on, it gets better.
Okay. Is there any specific activity seems to worsen this condition, like bending forward or sneezing, straining?
No,
Okay. Is it radiating somewhere other than the original site?
no, doctor.
Okay. According to your, can you rate your pain on a scale of 1 to 10? 1 would be no pain and 10 would be severe pain. How will you rate your pain?
It might be 4 on 10, doctor.
Okay. Do you have any problems in your speech? Any slurring of speech?
Speech, no, doctor.
Yes. No.
No.
Okay. Uh, is there any sensory loss, like any pin and needle sensation or any numbness in any part of your body?
No, doctor.
Okay. Any tingling sensation in your
No,
hands or feet?
no, doctor.
Is there any frothy urine?
No,
Have you noticed any dry skin, any loss of hair in your legs or hands?
no, doctor.
Okay. Uh, Miss, Mr. Raj, have you ever been diagnosed with any other medical condition in the past?
No, doctor, but the doctors are saying on a couple of occasions my blood pressure is quite high.
Okay. When did you last check your blood pressure?
It was a week ago and it was around 160 by 90.
Okay. Have they prescribed any medications for that?
No, doctor. They haven't prescribed me any medications.
Okay. Uh, Other than this high blood pressure, you don't have any problems, right?
Sorry, doctor, can you please repeat?
Uh, Apart from the high blood pressure, you don't have any high blood sugar levels, right?
No, doctor, I don't have high blood sugar.
Okay. Okay. Uh, Apart from that paracetamol, do you take any other over-the-counter medication without the doctor's prescription?
No, doctor, I don't.
Did, did you underwent any surgery in the past?
Surgeries? No.
Okay. Um, uh, what do you do for your living, Mr. Raj?
Doctor, I'm working as a painter.
Into- For how long?
Oh, it's been for last 30 years now.
Right. Okay. Are you sleeping well?
Yes. To be honest with you, doctor, I am sleeping all right, but my partner has been saying that I'm dozing off in the day.
Oh, okay. Uh, have your partner ever told you that you have been snoring in the night?
Yes, doctor. She's actually sleeping in the other room because of my snoring problem.
For how long have you noticed? Have she told you that you're having this snoring problem?
Oh, last 4, 5 months now.
Okay. Do you ever feel tired
Yes,
during the
doctor.
daytime?
I feel really tired, doctor.
Okay.
Doctor, you have 4 minutes left for examination.
Okay. Now I would like to examine the patient hands
Okay. All
for
right.
any palar cyanosis,
This is your
any mus.
patient. Okay.
Okay.
He doesn't have any pallor or cyanosis. What else would you wish to
Okay.
see?
Palmar erythema.
No, no palmar erythema.
I would like to check the blood pressure and pulse of this patient.
Blood pressure is 160 by 90 as given outside.
Okay. Is there any proximal myopathy?
No.
And I would like to check the patient, this gentleman's neck circumference,
Okay. It is around 20 inches.
20 inches. Is there, I would like to check the JVP.
Okay. JVP is not elevated, doctor.
Okay. And I would also like to check if there is any tremor in his hands.
Okay. There's no tremor. Which tremor are you checking?
Um, Forget the name.
Okay. As of now, there is no
Yes.
tremor that you can
Oh,
appreciate.
okay,
Okay.
okay.
Yeah.
And I like to check his mouth. Is there
o-
any high arch palate? I would like to check his tongue.
Okay. This is his tongue.
Mhm.
What
And
else?
I would also like to check his fundus in his eye.
Sorry, can you repeat?
I would like to check his eye, ma'am,
I.
and
Okay.
do the fundus examination.
All right, doctor. If you do fundoscopy, you will be left with 1 minute. What would you do? His eye is normal, by the way.
Okay. And I'll check for any pale, any cyanosis, ma'am.
No, absent.
Okay. And I would
Anything
like to
else,
do the
doctor? Yeah.
um, I'd like to examine the respiratory system, ma'am, for any
What exactly you want to look for in respiratory system?
crepitations, ma'am, any
Okay. So there are no crepitations per se.
okay, ma'am. And
Okay. Anything else, doctor? You still have 1 minute left. So in the exam, what would you do if you had
yes,
time? Yeah. You told crepitations in
uh,
the respiratory system. Crepitations are
yes,
not
ma'am.
there. What else would you do?
And I'll check the leg for any pedal edema.
Okay. As of now, he is not having any pedal edema.
Okay, ma'am.
Yeah.
Any scars in his chest or
Okay.
abdomen?
No scars. No abdominal scars also. Do you want to proceed to the concerns?
Yes, ma'am.
Okay.
Mr. Raj, what are your concerns?
Doctor, why am I having this problem of breathlessness and high blood pressure?
Um, Mr. Raj, based on your symptoms and your complaints, and after examining you, I think you are having a medical condition called obstructive sleep apnea. Have you ever heard of that? Do you want me to tell more about it?
Yes, doctor. I don't know what it is, doctor. Can you please explain?
It's a medical condition. It especially affect your upper airway. Uh, yeah, and that's why you are experiencing these breathing problems. And the leg swelling that you are experiencing might be due to uh, an extreme condition. It may affect your lungs. So that's why you're having the shortness of breath. So as for now, we want to do certain bloods and some imaging, and also do some special studies to find out the reason and to confirm your uh, reason for the breathlessness. Is that okay with you?
All right, doctor. So, do I require an admission right now? Is it an emergency?
Yes, we need to do some tests and we need to check your oxygen levels and we need to certain imaging to confirm the diagnosis, and we have to monitor you, and so you require an admission.
Okay. All right, doctor. So, could I be having a lung cancer, doctor? I'm really worried.
Uh, Mr. Raj, I can understand your concern, but we are not sure of anything as of now. So after the imaging and the blood results, we have we'll tell you the reason. Is that okay with you?
Okay, doctor. All right, your time's up. So, can you tell me the positive signs you have elicited in this gentleman, doctor?
Um, uh, can I tell the history or only the examination, ma'am?
Straight away, you have to tell the signs, no history.
Okay,
Okay?
ma'am. Okay, ma'am.
Yeah.
Ma'am, his blood pressure is high, around
Mhm.
160/90, and the only positive finding I can appreciate is this neck circumference is 20 inches, ma'am. That's it.
Okay.
And he looks cyanosed.
Does he? Okay.
I'm not sure, ma'am.
Okay. If you're not sure, don't comment on it. Okay.
Oh,
What is
okay,
very
okay, ma'am.
obvious, you can tell.
Okay, ma'am.
Yeah. What else was there, doctor?
He is obese, ma'am.
Okay.
Mm.
Anything else you got in the respiratory system or in any other system?
Um,
So you feel it is a normal. Rest of the things are normal.
and I'm not sure, ma'am.
Okay, okay. All right. Considering these signs, what are your differentials?
Ma'am, my first differential diagnosis be obstructive sleep apnea.
Okay.
Uh, Second, obesity hyperventilation syndrome.
Okay. Very good. What else?
Third,
If I tell you the patient had weight gain and constipation, anything else you would like
hypothy-
to? Yeah.
hypothyroidism, ma'am. Second.
Okay. Okay. All right. How will you investigate this patient, doctor?
First, do the general investigation. I will especially check his full blood count
Okay.
and thyroid function test, ma'am.
Very good. What else?
Uh, Renal function test,
Mm-hmm.
ECG, to rule out any right heart abnormalities, ma'am.
Okay.
Whether he's in failure, echocardiogram, ECG, ma'am, and ABG, ma'am, ABG, and I will measure his saturation, ma'am, pulse oximetry.
Okay,
I'll
doctor.
measure
What
his
is the
saturation.
specific
Yes, ma'am.
investigation to confirm a diagnosis of obstructive sleep apnea?
Polysomnography, ma'am,
Yes, polysomnography.
overnight.
Okay. Are you aware of any score, sleepiness score for
Yes, ma'am, Epsworth
uh,
sleepiness scale.
Epworth sleepiness
Yes,
score?
ma'am. Yes,
Okay.
ma'am.
Yeah, all right. So,
And
how will you manage this guy?
ma'am, first, general, I educate the patient about the importance of weight reduction in this case.
Okay.
And I didn't ask the patient his personal history, ma'am, like whether he's smoking or consume
Mm-hmm.
any alcohol, and I didn't ask the driving history. So if he's driving, I will ask him to stop driving
Very good.
until and the diagnosis is confirmed. And
Okay.
if he's smoking, I'll refer him to the smoking cessation groups. And if he is consuming alcohol, I'll refer him to the alcohol support group. And
Okay.
if this problem is affecting his daily life, I'll ask whether he's having any relatives to take care of him, and
Oh,
I'll admit the patient, ma'am.
okay. What is the medical management or any procedural management you can offer? He's
Um,
having
uh,
shortness of breath, right? For that, what you
yes,
use?
ma'am. CPAP, continuous positive airway pressure.
Mm.
First, I'll check the saturation, ma'am. Then I'll
Okay.
consider that to give
Any surgery you are
oxygen.
aware of that you can offer
Yes,
if
ma'am.
CPAP doesn't work?
Willow palato. Uh,
Yeah,
yes, ma'am.
pharyngoplasty.
Pharyngoplasty. Yes, ma'am.
Okay. All right, doctor, your time's up. We'll stop
Yes,
it
ma'am.
here.
Yes,
Dr.
ma'am.
Smilin, it was a very good attempt what you did. You came to the diagnosis. You
Yes,
tried
ma'am.
to cover 70% of the things in this scenario, but
Okay, ma'am.
some crucial history you missed. Okay. We'll discuss about it. Don't worry. It was a very good attempt. Okay.
Yes, ma'am.
Yeah. So coming to the history, like I told you, we need to be aware of all the checklist of the history that is mandatory in all clinical consults. Okay.
Okay,
onset,
ma'am.
duration, frequency, diurnal variation, triggers, relieving factors, associated symptoms. Associated symptoms, we can come back at the end. Okay.
Okay, okay, ma'am.
So next, what you will ask immediately, you'll go into past medical history, surgical history, drug history, allergy history, family history, alcohol, smoking, IV drug abuse, diet, sleep, mood, stress, job, driving, if relevant, travel,
Yes, ma'am.
sexual. And most important aspect in PACES is impact. What is the impact of the patient's symptoms on his day-to-day life? So this is very
Yes, ma'am.
important. Kindly do not miss any of these things.
Okay, ma'am.
Associated symptoms, you have to figure out based on the chief complaint you have got, based on the past history you have got, you need to decide which systemic review I am going to do in this patient. You are very well aware that whatever the chief complaint belongs to, shortness of breath means respiratory. So you are going to ask
Yes, ma'am.
about respiratory systems review. Then you have to ask general health questions. Then,
Okay,
based
ma'am.
on your suspicion of the differentials, you are going to go into detail. So, we are going to talk about high blood pressure scenario. What are the secondary causes of hypertension specifically today we are going to discuss. Okay.
Okay, ma'am.
Now, coming back to your case, this patient has high blood pressure and he had headache and shortness of breath. So, you evaluated the chief complaint well, but the problem is when you come to all of these things, okay, you have to do specific examination to the particular system, isn't it?
Yes, ma'am.
He's saying of early morning headache. Early morning headache could be a sign of space occupying lesion, correct?
Yes, ma'am.
So you have to do some examination pertaining to that. Okay. So coming to
Okay,
the
ma'am.
examination checklist in this guy specifically for OSAS, I am saying first, start with the hands, check for flapping tremor. The relevance of flapping tremor is carbon dioxide retention due to OSAS,
Retention.
right? Then you will
Yes,
check
ma'am.
for pulse, offer for blood pressure, check for proximal myopathy, check the mouth for any narrowed pharynx, check the nose for any anatomical abnormalities leading to snoring, check the eyes, and for pallor and icterus. Then you can offer
Okay.
visual acuity over there, fundoscopy over there. If you have time, you can check the extraocular movements to rule out any neurological problem. Then come to the neck, look if the patient is having any goiter. If there is a prominent goiter,
Okay, ma'am.
you have to do the thyroid sequence. Then
Okay,
come
ma'am.
to the chest area. I was specifically asking you what you are looking for in respiratory because these patients can develop pulmonary hypertension. So you have to auscultate and palpate for loud P2 or palpable P2.
Okay, ma'am.
So that is important. And
Yes,
he's
ma'am.
having occasional leg swellings. He might be developing right heart failure. As of now,
Yes, ma'am.
he's not having any signs, but you might have to say that in the diagnosis. Okay.
Okay, ma'am.
So this patient could be having a loud P2 and further complicated by right-sided heart failure. That is a possibility. Okay.
Yes,
Then,
ma'am.
neck circumference, obviously, you have checked in the neck. Then coming to the lower limbs, you have to check the pedal edema. It is a very simple, straightforward examination when it comes to OSAS, doctor. Okay. But
Okay,
when
okay,
it
ma'am.
comes to secondary causes of hypertension, there are multiple things that we have to examine. We'll discuss eventually. So, investigations again specific to this condition would be polysomnography, pulmonary function tests to look for restrictive lung disease, okay, chest X-ray, ECG, 2D echocardiogram to look for signs of pulmonary hypertension, and arterial blood gas analysis if the patient is having tachypnea. Okay.
Yes, ma'am.
And otherwise, you will offer CBP, SR, CRP, liver function test, renal function test. In case we are going to start the patient on any drugs, we will offer that. Otherwise, it's not required. Okay.
Okay,
Coming to
ma'am.
the specific management, conservative management, most important aspect is stopping driving for the patient. If driving is not stopped in this scenario, it goes against your welfare. And regarding weight loss, you have to counsel in the concerns only. Okay. So weight loss, because of the weight, you might be having this breathlessness symptom. So you have to lose weight. And we will be referring you to the dietitian. Okay. That is the
Okay.
important conservative management. If the patient was a smoker, stop smoking. Medical management would be this CPAP therapy, If CPAP is not working out, then you can try mandibular advancement devices that will help to clear out the airway. Okay. Then the surgery is
Yes.
uvulopalatopharyngoplasty. Okay.
Okay.
So
Yes, ma'am.
this is the management for OSAS. Now coming to secondary causes of hypertension. Okay, I'd like to share my PPT. Just let me know if you guys can see the screen. This is a very, very common scenario that is coming up these days. I'd like all of you to join in the chat box and please type the diagnosis if you are able to find it out. Okay. So see the images, try to put all of them together and come to a diagnosis. The first one is a palpitation, second one is excessive sweating, third is episodic headache, and fourth is anxiety or depression. What is this diagnosis? Excellent. This is pheochromocytoma. Perfect, doctors. So it is a cause of secondary hypertension. So investigation specific to pheochromocytoma would be 24-hour urinary plasma metanephrines or catecholamines, MRI or CT abdomen and pelvis to locate the adrenal mass, and MIBG scan if you are suspecting extrarenal disease. Then to rule out the complications of pheochromocytoma, you have to offer ECG and echocardiogram, fundus examination for hypertensive retinopathy, renal function test for hypertensive nephropathy. Coming to management, avoid stress, caffeine, and nicotine. Medical management is first alpha blockade followed by beta blockade. Surgically, you have to resect the tumor if it is resectable. Okay. Next, the patient is having muscle weakness, cramps, polydipsia, polyuria. What is the diagnosis? Excellent. I'll repeat again, muscle weakness, muscle cramps, polyuria, polydipsia. Yes. Yes, doctors. It is Conn syndrome. Okay. Hypercalcemia usually presents more oftenly with abdominal pain, depressive symptoms, renal stones, rather than polydipsia and cramps, doctors. So all these fit together well with cons. So for that, the specific investigation is plasma, aldosterone, and renin ratio. Saline suppression test you can offer. CT imaging to rule out any adenoma. In case of if you're considering surgery, in order to know if it is unilateral or bilateral cons, then you have to do adrenal vein sampling to know which side adrenal gland is affected. To rule out complications like hypokalemia, you offer serum electrolytes, ECG for arrhythmias, renal function tests, again for chronic hypokalemic nephropathy. The management would be sodium restriction and blood pressure control, and you can start the patient on spironolactone or eplerenone. Again, surgical treatment is the last resort of treatment. This is very easy. What is this diagnosis? Yeah. And in Cushing syndrome, I would really advise you guys not to comment words like moon face, buffalo hump. Please do not do that. You can just say there is some excessive fat deposition behind the neck. Okay, like that you can use. And enlarged face. These things you can use, but don't say moon facies or buffalo hump. Okay, the patient is having Cushingoid features here and abdominal striae. And in picture C, you can see acanthosis nigricans. Okay. So Cushing syndrome, again, the investigations are straightforward. First would be salivary cortisol or 24-hour urinary cortisol, followed by overnight dexamethasone suppression test, plasma ACTH level to localize if it is a primary or secondary Cushing's, MRI pituitary or CT adrenal, again for ruling out primary or secondary Cushing's. So Cushing's disease is secondary, Cushing's syndrome is primary. So to rule out complications like diabetes, we will offer oral glucose tolerance test, HbA1c levels, DEXA scan to rule out any bone deformities or osteoporosis, and lipid profile and echocardiogram for metabolic and cardiac effects. So the management is treat the weight loss. First is weight loss, referral to the dietitian, and offer protection for bones. Medically, you can use drugs like ketoconazole, metyrapone, and surgically, you can do transpenoidal resection if it is a pituitary cause. If it's adrenal cause, then adrenalectomy is the surgery of choice. Now, this one you are going to guess. No, no. Yeah, thyrotoxicosis. Yes, excellent. So here the patient is having heat intolerance, palpitation, and tremor in the hands. Okay. Thyrotoxicosis, you are very well aware. Thyroid antibodies, thyroid function tests, and don't forget to offer imaging for thyroid doctors. It's very important. And complications are obviously arrhythmias like atrial fibrillation, so ECG. Osteopenia can be there, so bone profile. Management would be avoiding stimulants and ensure that adequate nutrition is there. You can offer antithyroid drugs like carbimazole or propylthiouracil. Counsel the patient regarding side effects like neutropenia, and if they develop any rash, they have to come back to the hospital. So that comes under safety netting, and give beta blocker to the patient. Surgically, you can do radioiodine therapy or total thyroidectomy if the symptoms are worse. In any case of thyroid with a goiter, never forget to ask about 3Ds: dyspnea, dysphonia, dysphagia. So if they are there, then it is a severe disease. Again, an easier one. Yep. Yes, straightforward. Exhausted person, cold intolerance, and goiter. So this is hypothyroidism. Again, the investigations do not change much except for antibodies. Here it is TPO antibodies. Okay. In thyrotoxicosis, we do TSH receptor antibodies. Here the patients can have dyslipidemia. So we will do lipid profile, ECG for bradycardia, and electrolytes because the patients can have hyponatremia. Management, avoid goitrogenic foods. Okay. Then you can offer levothyroxine medication, usually starting at a dose of 12.5 to 25. And if they have severe goiter, then offer thyroidectomy. Okay. Coming to the next secondary cause of hypertension. This is a little difficult. The patient is presenting with headache, blurring of vision, and blood pressure discrepancy is there. So this is a major clue. Yes. Excellent, doctors. So this is coagulation of aorta. So coagulation of aorta, basically you have to offer all the tests to look at the vessels. So first offer blood pressure measurement on all the four limbs, echocardiography to visualize the narrowing, CT or MR angiography for detailed anatomy where exactly the coagulation is there. Then you will do echocardiogram to rule out any left ventricular hypertrophy or bicuspid aortic valve because these are often associated with coagulation, and fundoscopy for hypertensive changes. And medical management would be beta blockers for blood pressure control and aneurysmal protection. Surgically, you can offer balloon angioplasty or surgical repair. Okay. This one you're going to guess. Flank pain is there, nocturia, hematuria, and history of renal disease. Very common case. Yes, excellent. This is a case of ADPKD. So ADPKD you can expect in short stations, or they can keep as a complication like renal stones or abdominal pain in a consultation station. So make sure you're offering the appropriate investigations, ultrasound on CT's abdomen to locate the renal cysts, urine analysis for proteinuria, hematuria, renal function test, genetic testing specifically for PKD1 or PKD2. For complications, you have to offer echocardiogram and screen for hepatic or pancreatic cysts. One important test missed in this list is MRI of the brain if you are suspecting any subarachnoid hemorrhage, or CT of the head also you can do. For aneurysms, you can do MR angiogram. Okay. Management would be salt restriction, hydration, avoiding nephrotoxins, offer ACE inhibitors or ARBs for blood pressure control, and tolvaptan. They say that it will delay the progression of this cyst size, so tolvaptan is indicated. Nephrectomy if the patient is having severe compromise. Okay. Anyone? What is the diagnosis? Excellent. So this is renal artery stenosis. Resistant hypertension is the main clue. Resistant hypertension means even if the patient is on 2-3 medications, the patient's blood pressure will not be under control. Sudden onset will be there, and you can hear a renal bruit when you auscultate the abdomen. This is the reason auscultating abdomen is very, very important. So make sure you're auscultating every time you touch the abdomen. Okay. So renal artery stenosis, again, the specific investigations are Doppler ultrasound, CT or MR angiography as the confirmatory test. Okay, and to rule out complications, you can do ECG echocardiogram and fundus for hypertensive retinopathy. Basically, this left ventricular hypertrophy and fundus are for complications of hypertension, not specifically to the renal artery stenosis per se. Okay, and conservative management would be stoppage of ACE inhibitors or ARBs. Be very careful, because if there is bilateral renal artery stenosis, then there will be hyperkalemia when you start these medications. So do not start it if there is bilateral RAS. However, you can offer beta blockers and calcium channel blockers for blood pressure control. So the last one is drugs. Can you tell some drugs which will cause hypertension? Drugs causing hypertension. Perfect. Cyclosporin, OC pills, steroids. Yes. Tacrolimus, NSAIDs. Very good. So this patient, I told 2 to 3 times the patient is taking medications or painkillers. But if it was multiple times, then NSAIDs causing hypertension can be a differential. In this patient, it was very minimal. So make sure that you are ruling out all these medications. You gave me a better list than I made. Thank you. Okay. So medications like NSAIDs, OC pills, steroids, immunosuppressants like cyclosporin, erythropoietin, all of these can cause hypertension. So for confirming diagnosis, obviously a better history is the key, and we can check the renal function test and serum electrolytes. Okay. Again, for hypertensive assessment, you will do ECG and echocardiogram. If it is drug-induced hypertension, stop the offending drug, adjust the lifestyle of the patient, and replace with a safer alternative. Okay. So if you're confused as to what to examine in a case of secondary hypertension, in this case, I have given shortness of breath also. If they give only uncontrolled blood pressure, then this is the examination checklist that you have to do. You can take a screenshot of it if you need. Okay. So starting from general examination, look at the habitus of the patient. That will tell you if he is overweight or underweight. So if he is a patient with high BMI, Cushing's, hypothyroidism, okay, these things are important. If he's thin, consider hyperthyroidism or any malignancy as a cause. Carefully inspect for scars in the thyroid area. That will give you again post thyroidectomy. The patients could be developing hypothyroidism. Okay. And look at the palm for any sweatiness or palmar erythema. That can be a sign of pheochromocytoma or thyrotoxicosis. Then, obviously, the blood pressure you will be offering. If there is a differential blood pressure, it is coagulation of aorta. If it is high blood pressure, then there are multiple causes like Cushing's or thyrotoxicosis. Okay. If it is diastolic hypertension, it is hypothyroidism. Coming to the head and neck area, look at the eyes of the patient. If there are any signs of graves like exophthalmos or proptosis, you make sure that you're checking for lid lag and lid retraction. Okay. Then offer fundoscopy for papilledema or any hypertensive changes. Look at the neck for any goiter. Auscultate for carotid bruit. That will be a sign of atherosclerotic disease. Look for raise of JVP for heart failure. Okay. Then look at the mouth area for any adrenal disease. Okay. Cardiac examination is important because pulmonary hypertension can be found there and coagulation of aorta. The patients can have some murmurs like bicuspid aortic valve can be causing a stenosis murmur. So make sure you auscultate the heart. And if you are suspecting obstructive sleep apnea, then you can check for neck circumference. Auscultate the lung basis for any crepitations due to heart failure. Now expose the abdomen of the patient. Look for any striae of Cushing's and make sure you're auscultating the abdomen for any bruit. Ballot the kidneys for polycystic kidney disease. Okay. If you are suspecting a Cushing's disease, then make sure you are checking for visual fields also and proximal myopathy. How do you check proximal myopathy? Ask the patient to cross their hands and stand up without support. If the patient is not able to do that, then proximal myopathy is positive. In case of hypothyroidism, you can check the knee reflex. The ideal reflex is hung up reflex. That means the relaxation of the muscle will be very slow in case of hypothyroidism. If the patient had tingling sensation and numbness, then offer to check the sensations distally, at least vibration you have to check. Okay. In case of Cushing's, the additional examination would be palpation of the bones in the back for any osteoporosis signs. So these are the major things that we are looking for. So systemic clues in the last column, you can see these are just like a single spotter that will give you the diagnosis. You can take a screenshot and go through it once again. Okay, doctors, any doubts in this specific scenario or in scenarios which are being given as uncontrolled blood pressure? One important aspect in case of uncontrolled blood pressure or uncontrolled blood sugar, you have to ask about macrovascular, microvascular complications, okay, like heart issues, kidney issues, eye problems, peripheral neuropathy, peripheral vascular disease. Okay, these are very, very important aspects to establish. And how is the blood pressure control? What are the medications? How are they taking the medications? Compliance to medications, any recent addition of medications, any side effects of the medications that the patient has used. All this includes history. Okay. In the real exam, doctor, what happens is they'll remind you at the 13th minute that 2 minutes is left. When the examiner says 2 minutes left, you have to turn to the surrogate and ask concerns. So after the concerns time is over, they will immediately start asking why. No problem. Thank you. Does anybody want to do a communication? Any volunteers who want to do it?
Yes, ma'am, I'll take it.
Okay, doctor. All right. Um, are you able to see the screen, Dr. Supriya?
Yes, ma'am.
Okay. Can you please start, doctor?
Yes, ma'am.
Yeah.
Hi, am I talking to Mr. Yunus, son of
Yes,
Mr.
doctor. Yes.
How may I address you, Mr. Yunus?
You can call me Eunice, doctor.
Uh, Hi, Yunus. I'm a doctor in clinics today. I'm here to talk about your father. May I know what you know about him already?
Doctor, I know that my father was suspected to have a cancer. I went through the internet and I'm really hopeful about his problem, doctor. So I have read a lot that there are very good treatment options available as of now. So I'm really hopeful, doctor. I'm expecting you to reveal the same thing to me today.
Okay. What exactly were the symptoms your father was suffering from, Mr. Yunus?
Yes, doctor. He had some weight loss and he was feeling really tired. So we got him to the hospital. The doctors initially told that he could be having a cancer. Uh, but like I told you, when I went through the internet, I just feel like he can recover well, doctor.
Oh, I'm sorry to tell you, Mr. Yunus, the news is not that good.
Is it so, doctor? What has happened, doctor?
Mr. Yunus, your father is having a pancreatic cancer. And not only that, it is pancreatic cancer localized to the pancreas organ, it is spread otherwise to involve his liver as well. Liver is an organ which is little distant of pancreas. So when an organ which is distant of pancreas is involved, usually what the outcome we are expecting to be would not be so good. It usually, unfortunately, is little grim. Uh, Mr. Yunus, do you want somebody else with you? Are you with me?
I am with you, doctor, but I'm not able to believe what has
Do you
happened.
want some water or something?
No, no, doctor, I'm fine. I'm fine.
Are you comfortable? Can I go ahead and speak about what further can we do about it?
Yes, doctor. Please tell me what happened.
So, Mr. Yunus, the management plans of this pancreatic cancer, I'm sure you Googled and found out that it is resectable and there are therapies, chemotherapy. But unfortunately, in your father's case, it is spread to the liver, as I told you. So this chemotherapy surgical options are ones when we give it to people in whom the cancer is just localized. Surgery is a very good option, especially if the big resection. However, the lifespan would have been the 5 year lifespan would have been there 1 to 5 years. But unfortunately, in your condition, the news is not so good.
Okay, doctor. All right. So, what are you going to do about him?
And in fact, I'm very saddened to say, Mr. Yunus, the mortality rate is quite high, and the 5 year survival rate would be less than maybe 1%.
Oh my God. So, he is going to die very soon, isn't it?
Yeah, yes, I'm very sorry to tell that, Yunus.
How many days he actually has, doctor? You can be frank with me. I don't mind.
Are you sure you want to listen to this?
Yes, yes, doctor. Tell me how many days he will have.
Unfortunately, few months.
Okay. So, are you going to discharge him right now, doctor?
No, Eunice, we have options. So the good news is there are options. There are treatment available in the form of palliation. Palliation doesn't only mean a relief of pain. There are a lot of other things we can do. We can manage his fatigue, his complaints of reduced sleep, pain, and difficulty to walk around, and his activities of daily living. If he's having any constipation, that can be taken care of. If he's having lack of appetite, that will be taken care of. And of course, pain management as well. Uh,
Okay.
how does that sound to you?
Uh, That's all right, doctor, whatever you're doing, but are you really sure that you can't give him any medications to kill the cancer?
Unfortunately, I may not be in a comfortable state to comment on this. So the best thing I would do is I could arrange for another consultation with my consultant, with the oncologist, and we
Okay.
can have another a consultation on this. Is it okay with you, Mr. Yunus?
Okay, doctor, that's all right.
Any other concerns, Yunus?
Doctor, I want to have a second opinion regarding this matter. I still believe that my father can be treated. He's a very strong person, doctor. I think if you offer chemo also, he will react. So I just want to have a second opinion. Can I go ahead?
Yes, Yunus, I will respect that. First, foremost, we can have a arrangement at the earliest with the consultant, as I told you here. And if you're not happy further, we can go ahead with the second consultation or cross consultation you're talking about.
Okay, doctor. Thank you.
Thank you, Yunus.
You still have 4 minutes.
Any other concerns, Mr. Yunus?
No, doctor. I don't.
Okay. Can I call for a meeting like next week or at the earliest this tomorrow or day after tomorrow only? Do you want to come along with somebody else?
Yes, doctor, I would really love to come because I want to know about more treatment options. And I don't want to take a tiniest risk also. I don't want to keep my dad away from medications.
Okay, we can arrange for meeting at the earliest. I'll just check my the diary and we'll talk to my consultant and get back to you on this on the second meeting. Is it okay with you, Eunice?
Okay, doctor. All right.
Okay.
Should we stop here, Dr. Supriya, and discuss?
Yes, ma'am. I'm sorry, I don't know how to take it forward.
No problem, no problem. You tried well. Okay. So this case, as you can see, it is a case of palliative care. Okay. Hello.
Yes, ma'am.
Yeah, you're able to hear me? Sorry.
Yes, ma'am. Yes, ma'am.
Yeah, so this was a scenario about palliative care. So, what is given to you the information is that the patient has pancreatic cancer that is spread to the liver, isn't it? So now this person is a non-medico. He doesn't know what pancreas is. He doesn't know what liver is. What would be better for you is to make a diagram initially. Okay, a small diagram. Okay, so this
Okay,
is
ma'am.
the liver. Okay, that usually helps to purify the blood and remove any excess waste from the body. Okay, some toxins. Okay, and there is a part called pancreas that usually produces some proteins that help with the control of blood sugar level. Okay, what
Oh,
happened is your father had a growth initially in the pancreas. You might have heard about it. So he's saying, no, I know that my father has cancer, but he's not being specific. Did you observe?
yes, ma'am.
So then you can say this. So he had a cancer of the pancreas, and you show the diagram that you have made. You have those 5 minutes outside with you, correct?
Yes, ma'am.
In those 5 minutes, make sure that you are drawing a small diagram, a rough, vague diagram. Okay. And you
Okay.
just show it to him. So from this part of pancreas, the cancer has now spread here. So that is how you are expected to explain about it. And even before you start all of this, the first thing is to confirm the patient's identity. Okay. When you
Yes, ma'am.
prepare the 5 minute notes, the first thing you have to write is, who am I speaking to? What is my role? Okay. What is the patient's name?
Mm.
That is important. So he is Yunus. Who is he? He is son of Mr. Khalid. So that you have to confirm. So I'm speaking to Mr. Yunus. Am I correct? Yes, doctor, I am Yunus. So you are son of Mr. Khalid Ali, 72-year-old gentleman. Is it right? Yes, doctor. He is my father. So you tell him that I have your father's permission to speak with you. If it is not given in the scenario specifically, then you can assume that you have the permission.
Okay, ma'am.
Okay? So you just tell, I have the permission to speak with you from your father. Usually they'll give in the scenario, doctor. Otherwise, you tell this. I have permission to speak with you regarding your father's health condition. And after telling that, what should you ask initially? The first question you should ask is, can you tell me the understanding of his health condition so far? Or if you want to keep it in a simple sentence, how much are you aware of his health condition so far? Then he will tell you, doctor, my father had fatigue, weight loss. We came to the hospital. They told it is a cancer. Then he told he's really hopeful about the treatment. So, what you said is right, but I would tell you to be uh, more empathetic, okay? And
Okay.
do a little bit of drama, okay? The
Okay,
thing
ma'am.
is, I understand that you're really hopeful about your father's recovery, but I have really some I have really something unfortunate to tell you. Oh my God, what happened, doctor? I'm really sorry because we have found that his cancer has spread from one part to another. That is, it has spread from his pancreas to liver, and show the diagram that you have made.
Okay, ma'am.
Okay. So when you are empathetic and you reveal in this way, it will not look like you are revealing the diagnosis abruptly. So you are giving a warning shot that something bad is about to happen. Okay.
Yes.
And you are revealing the news. After that, some surrogates, if they are very well trained, they will cry, they will do a lot of things, and you have to wait for their reaction. Okay. After
Okay,
you
ma'am.
reveal the news, don't speak anything, just observe how the person is reacting. Okay.
Okay, ma'am.
Then wait for some 20 seconds or so. Then you offer, do you want any tissue or do you want some water? Okay. Once they settle down and they give you the eye contact, then you ask them, is it okay if I go ahead or you want more time? Okay. After
Okay.
that, if they say, go ahead, doctor, then you say, see, at this point of time, we can't give medications to kill the cancer cells, nor we can do any aggressive procedures. Okay. So we are going to offer him palliative care and stop. So, are you aware of palliative care? Have you ever heard about it? Then he will say, no, doctor, I have no clue what palliative care is. So, how do you describe palliative care? Palliative care is a form of treatment wherein we are going to prioritize comfort of the patient
Okay, ma'am.
rather than aiming at curing the disease. Okay.
Okay. Okay.
So, this will include taking control of or taking care of symptoms, like if he is in pain, we will give him painkillers. We will give him some sips of water to make sure that his mouth is wet. We will be changing his positions in the bed. Okay. In case if he has any hard stools, we'll be offering some stool softeners. This is the kind of care that we are going to take. Next time, what he will say, doctor, I really feel that you are giving up on my father. I just feel that you're finding excuses not to treat him because he's an old man. So, how will you address that? You have to tell, no, we are not going to show any bias in terms of age or gender. Okay, every patient is treated equally. However, your father is not in a position to receive aggressive medications right now. That is why we are prioritizing his comfort. Okay. After that, you have to explain what is the team mean. Who are there in the team? In a palliative care team, there will be specialist nurses, especially Macmillan nurses. They call it in UK for the cancer nurses. Okay, Macmillan nurses, cancer doctor. Okay, his problem is in pancreas, so gut doctor. Okay. These things you have to mention. So there are multiple specialists who will come together to prioritize his comfort and relieve his pain. And in any patient who is above 65 and is chronically ill, you have to ask about advance directive and lasting power of attorney. So these are new concepts to us, so no problem. Advance directive means usually in UK what they do is the patient will write a document how they wish to be treated in their end days of life. For example, I don't want to be on a ventilator. Don't give me CPR. let me go away. So like that, they in front of a lawyer, they will write and they will sign the document. That is advance directive. How we are supposed to ask that to his son? So has your father ever signed any document of how he wished to be treated in his last days when he is not in a position to say so? For example, the patient is active, he will say then and there only, no?
Yes, ma'am.
In case if he is confused or completely sedated, then you have to take this advance directive. Okay, don't worry if he
Okay.
is conscious or unconscious here. In any chronically or terminally ill person, you have to ask about advance directive. Okay,
Yes,
next,
ma'am.
that is advance directive. Lasting power of attorney means, has your father appointed anybody to take healthcare decisions on his behalf when he is not in a position to do so? That is lasting power of attorney. Only if it is written in a document and signed, it is valid. Okay, usually
Oh,
in scenarios they will confuse you. I am his son, no, I have every right to take decision on his behalf. Until unless there is a document written by the patient that they can take decision, you cannot take their word. Okay, what you can
okay.
do is, I genuinely respect your opinion about your father's treatment, however we have to stick with the team's decision.
Okay, ma'am.
Okay, so you are supposed to ask advance directive, lasting power of attorney. And see, communication is a bunch of number of things. So you have to ask about history. What history is relevant in this case? Social history is important. Who is taking care of your father? Is your father dependent on anybody? Is anybody else dependent on your father? Okay, is he able to manage his day-to-day works? Okay, does he need some social support? Are you financially supported? Now the son has to take care of his father, no?
Yes,
We
ma'am.
have to offer financial support also. Are you financially supported? No, doctor. So in that case, we will offer some social services that can offer help to you. Okay.
Okay. Okay,
And
ma'am.
there are some services called chaplain services. CHAPLAIN. Chaplain services means, you see, every religion will have their own head, like a priest or a church father. Okay. So what they do is, they come to the terminally ill patients and they do some prayers for their well-being. So if the patient is a religious person, then we can offer chaplain services also.
Okay, ma'am.
Okay, so these are a number of things that you need to ask doctor. So if you do all these things, then the palliative care scenario is very well done. Okay,
Okay, ma'am.
it was your first time, you tried very well. We might do another one in the next session. Okay, so
Okay, ma'am.
all these things you have to consider. Okay.
Okay, ma'am.
Okay, doctor, thank you.
Thank you, ma'am.
Thank you. All right, doctors, thank you so much for attending our session. Let us know if you want to have any sort of improvements. Your feedback is appreciated. You, even in the group, you can message us. Okay. Thank you so much for attending. Thank you.